Welcome back. Just going to step up here. Okay. Well, welcome back to this session. I know we're kind of a little bit off time, but we'll try to end close to noon for the luncheon. And we have a short session, but a very interesting session. In the third part, Dr. Dean will be presenting a series of very unusual cases, and I will not have a challenging case because I'm deferring to him because I really like his talk. And we're going to start this morning, this session, with Dr. Pop. Thank you very much for coming. And he's going to talk about how to recognize and avoid nerve injuries. And I personally, one of the first cases I ever did an ablation on had a paresthesia that never went away. It's very disconcerting to any of us, so this is a good talk to pay attention to here. Thank you.
Is this the remote? Let's see. Hi, I'm Andrei Pop. I'm an interventional cardiologist and vascular specialist at Alexian Brothers. It's kind of funny, I had paresthesia on my first case as well, so that's a disturbing trend that we'd like to avoid. So these are a few things that I'm going to talk about. We're going to move right along. Basically, all of us went through medical school and we kind of have vague memories of what nerves go where, but we're concerned about sensory and motor nerves. The motor nerves, thankfully, are much less affected, so we'll start with sensory nerves. The sural nerves accompanies the small saphenous vein superficially in the calf. It is purely sensory. Our colleagues oftentimes biopsy it when they need a nerve biopsy, so that tells you it's not that crucial. In the proximal third of the calf, you have separation between the nerve and the small saphenous vein. So there, the risk of injury is much lower. However, as you move distal, and this applies to the greater saphenous vein as well, it comes closer to the vein, and the chances of injury are much higher. The saphenous nerve, which accompanies the greater saphenous, also purely sensory. And again, as you move distal into the calf, it is much closer connected to the vein, so the chances of injury are much higher. These are the distributions of the various nerves in the calf. There'll be a little quiz at the end, so you have to memorize this. There's a lot of variability in the way these nerves branch, but these are the typical locations where you're going to have deficits once you injure the nerves. And the location right above the ankle is where I see most problems. Now, granted, some of the patients that we're dealing with, especially if they have very advanced venous insufficiency, may already have problems with numbness, tingling in those areas. And half the time when I do informed consent with these patients and I tell them you may end up with numbness in your ankle area, they say, well, I can't feel it already, so what difference does it make? The most important motor nerve that you want to be aware of is the peroneal nerve. It's the terminal branch of the sciatic nerve, and it is motor and sensory. And motor is underlined because if you injure this nerve, you end up with foot drop, and your patients are very unlikely to love you after that. This is the nerve that wraps around the head of the fibula, so this is the nerve that sometimes is compressed when you're sleeping on one side or something and you end up with transient foot drop. I like a lot the little danger triangle there. That's the area where you have most likelihood of injuring the peroneal nerve, and that's why when I ablate the small saphenous vein, the moment the small saphenous vein starts diving deep in the popliteal area, I stop ablation there. So I never go in the small saphenous vein where it dives towards the popliteal. Short refresher on cross-sectional anatomy. There are the major branches that you're going to injure as we discussed, but you also have a number of smaller superficial branches, some of them named, some unnamed, that you can pull out with phlebectomy. So you have to be careful with these because patients, will have a lot of pain when you touch these superficial branches. As we're following down, you can see the genesis of the tibial nerve and the peroneal nerve, and then you can see the nerves starting to accompany the veins as we discussed. So we're going to go really quick through this. Tremendous amount of anatomic variant. The level of bifurcation is very variable, and you have to be very careful when you get in the area where the peroneal nerve is likely to be. So that's the popliteal fossa. One neat trick is that you can actually identify these nerves on ultrasound. It's not very easy, and as almost always with ultrasound, the easiest way to find things is start somewhere where you know where things are and make your way distal. And generally the easiest way is to find a bigger structure and follow it as it bifurcates in smaller structures. And you start with a sciatic nerve, which is hyperechoic, superficial, and slightly lateral to the popliteal vein. And then the nerve travels laterally, and you can identify its bifurcation, and you can identify the peroneal and the tibial. Actually, the best resource for this is in literature and in online videos for nerve blocks from anesthesia and from surgery. And there's actually some very neat videos online that show you how to identify these structures. Signs of nerve injury. You touch a structure, you don't know if it's a vein or a nerve, the patient jumps off the table. You always have to stop and think, did I pull a nerve? If the pain is shooting, then you're probably better off putting that structure back in without cutting it off because you're dealing with a nerve. If you injure a nerve either by phlebectomy or by thermal ablation, eventually you're going to get delayed numbness and hopefully not hyperesthesia. I've never had a case of hyperesthesia. I've had several cases where the patients have residual numbness. I always tell them it's likely to get better within a few weeks to a few months, but in rare cases it can be permanent. The foot drop with the injury of the peroneal nerve we already talked about. Strategies to avoid nerve injury. I think the main thing is you only need to ablate the refluxing segments. So if you have somebody who has only above the knee reflux of the greater saphenous vein, there's no reason to go below the knee. So especially in younger people, I try to stay away from going too far down below the knee. Now, on the other hand, if you have somebody who has massive varicosities, nasty changes in their skin, ulceration, I've gone to the ankle, and in those cases, the risk-benefit ratio changes. So you have to be careful where you go below the knee and how far below the knee you go. And I used the degree of disease to guide that, the patient's age. Persistent ulceration despite proximal treatment is another good reason to treat distally. And anatomical reasons. If you go below the knee and you identify a big cluster of branches that are coming off your greater saphenous vein, and you want to limit the flow of blood into those branches, that may be a good reason to go below the knee. Below the knee, I'm exuberant in the amount of tumescence I give because, as you saw earlier, there is some separation between the nerve and the vein, and the more tumescence you give, the more likely you are to separate the two and to provide a heat sink to insulate the nerve from the heat from the vein. I tend to use less energy below the knee, and as I said, I stop the small saphenous vein ablation as soon as the vein starts diving deep in the popliteal fossa. And whenever possible, I try to identify the peroneal nerve on ultrasound. Other injuries beyond nerve injury, obviously DVT-PE can happen. I always do an ultrasound at the end of the procedure. I do an ultrasound at a week later. I've never had a case of DVT that wasn't present at a week later. I actually never had a true DVT case. I've had cases where clot will extend into the common femoral vein or in the popliteal and be attached in the superficial vein, but not more than that. Skin burns and discoloration can occur with thermal ablation. That generally happens with veins that are very superficial, generally less than 1 centimeter from the skin level. Again, a reason to use aggressive lidiotumescence and to consider phlebectomy or high ligation as an alternative, because generally, even if you're successful in ablating without skin burns, these veins that are very superficial will indurate, and the patients will not have a good sensation as a result of that, and they'll complain of feeling the vein for a long time. The other way you can injure the skin is if you don't stop in time when you're taking the laser out, and you don't want to burn the skin using the laser. In terms of taking out nerves with phlebectomy, stop if the pain is intense, if there's shooting pain especially, know the nerve anatomy, use the ultrasound as needed, and when in doubt, put it back in. So that's it. Thank you very much.
Okay, my topic will cover just a little bit of the previous Dr. Pop's talk. So how to treat the small saphenous vein and the thigh extension branch, or the vena Giacomini, because both are continuous sometimes, so you should know how to treat both of them. This is the anatomy of the small saphenous vein. This is just a pictorial here that we can see, as we discussed earlier, the tibial nerve, the peroneal nerve. So we have to be cognizant that these structures are close, and like Dr. Pop says, keep your laser filament or your radio frequency filament out of the area. We call it the straight rule: never go down, always keep straight, and you'll be okay. We're going to show you what this looks like on the actual ultrasound. And you can actually, as mentioned before, pick these up with a little bit of experience. This is the tibial nerve right here. You can see it has little fasciculations in the bundle. And this is the popliteal vein artery. Here's the short saphenous, will be up here. So you can see it right here. There's pretty close distance. And there's some papers actually written about the distance between the peroneal nerve and the branch of the saphenous. And the average distance is around 2 centimeters. So it's pretty close. Clinical manifestations of short saphenous reflux. They can be anywhere from class 2 to class 6. This is actually a patient has a lateral ulcer secondary to short saphenous insufficiency. This patient was seen in the earthquake after Haiti, about a week after earthquake. You see our operating table here is a desk. Couldn't do much for him because it didn't hang a sotradecal. The guy had an ulcer for 3 years. Secondary, you could palpate the short saphenous vein was huge. Approximately 12% of patients will present with SSV insufficiency alone. So what's the treatment? The treatment has been described for isolated short saphenous reflux, surgery, ligation and stripping, which is associated with a very high reoccurrence rate, approximately 47% recurrence rate if you do a ligation of the SSV. So it really should be avoided nowadays. I think only in England do they still do this. And I think they're getting away from it. As mentioned before, you're more prone for nerve damage if you go in there and start messing around and dissecting around the tibial nerve to try to ligate the short saphenous. Thermoablation, most reported studies. There's a slight advantage of laser over RF, but the success rate at 2 to 3 years is anywhere from 85 to 95%. Energy target is around 60 joules per centimeter, of course, adequate tumescent. Foam sclerotherapy delivered by a catheter in experienced hands, either through a catheter or through MOCA, is associated with a 90% successful ablation of the short saphenous vein. In fact, I treat a lot of SSVs with foam sclerotherapy alone and have excellent results. Patients that cannot afford to have the thermal ablation, don't have insurance, squirt them with some sclerotherapy foam solution, 2 or 3 locations, or use a small catheter. It's almost 100%. And do a phlebectomy. Complications, less than 1% in most reports with laser ablation or foam sclerotherapy. DVT with foam sclerotherapy is most often in the medial gastrocnemius muscle vein, and it does not propagate. Pulmonary emboli, rare reported cases post-foam sclerotherapy, and one with RF. Nerve damage can occur after thermal ablations, usually related to the sural nerve, although there are reports of peroneal nerve injury, and I do defend a lot of doctors in lawsuits. I'm never a plaintiff lawyer. I never do that, but I do defend. And peroneal nerves are pretty much defenseless if that happens, because you'll know it if you activate that laser or RF and that patient has a lot of pain. All of a sudden, stop. If you don't, you're going to have permanent damage. Another important fact is to remember when you apply compression dressing post intravenous ablation of the greater or short saphenous vein to actually pad the lateral fibular head, because the perineal nerve at that location has absolutely hardly any blood supply. It's all fed by small capillary network. And there's a very common syndrome in people that harvest rice called Gardner syndrome, because they squat all the time. And many of these people have foot drop, great percentage of them. Just by squatting, you can actually get foot drop for long periods of time. So it's an important point to pad that area. Complications, as mentioned, it's very, very rare, but long as you keep the laser filament straight and don't go down the SPJ, you're going to be okay. There have been some reports that show the perineal nerve may be as close as 15 millimeters from the SPJ. So stay away from the SPJ. Okay, that's the most important thing, and you're going to be okay as far as that's concerned. The vena Giacomini or thigh extension branch. Some of the times you'll actually scan these patients and will have continuation of the intersaphenous connection between the greater and the short saphenous vein called the vena Giacomini, or now it's called the intersaphenous branch. And you know, they keep changing names every 2 to 3 years. I think it gives them a reason to go to Paris and mess around with the nomenclature. But Giacomini found this, the vein of Giacomini was found in the original dissection in 72% of the patients, 72% of the cadavers. The SSV connected directly to the GSV in 52% of the cadavers. Anatomical variations did occur. It can connect to the femoral vein by a perforator, or it can be by small tributaries from the sciatic nerve vein. So Dellis in Journal of Vascular Surgery 2004 examined 301 legs, found the vein of Giacomini present in 70% of the legs. Okay, now it's also kind of called the thigh extension branch, so it can extend all the way up or part way up, but it can be incompetent and should be treated if it is. The vein of Giacomini was present at the whole vein, 70%, and then you can also see the differentiation here, that there was difference in termination. Some in the mid-thigh, middle thigh, upper thigh usually connected to the GSV. The incompetent vein of Giacomini was present in 4% of the almost 5% of the patients. But when short saphenous insufficiency occurred, the vein of Giacomini also reflux in about 12% of the patients. Similar findings were found by Nikos. Anatomically, the vein of Giacomini has 3 distinct findings. It usually connects with the SSV and the popliteal fossa in the fascial envelope between the semitendinosus, semimembranosus muscle and the medial head of the biceps. It lies between these muscles. As it courses up, then it courses the mid-thigh, it becomes superficial, penetrates the fascia, and then connects with the greater saphenous vein. So it lies deep in the fascial envelope in the mid-thigh, but it's still safe to do procedures here, intravenous ablation if you have to, because you're still quite a ways away from the sciatic nerve. So here, refluxing vein of Giacomini may have 3 etiologies. It may be transmitted from the SSV if there's no valve, okay? It may be transmitted inferiorly from a perforator, or it can have retrograde transmission from the GSV. That's rare, but it does occur. Usually the vein of Giacomini is an incidental finding unless there's an external branch that connects from the vein of Giacomini to superficial varicosities. So anybody that has varicosities in the thigh, posterior thigh, should be really carefully scrutinized for a vein of Giacomini or a thigh extension branch. That's probably where they're from. Short saphenous varices do not originate in the thigh. Perforators from the popliteal and the gastrocnemius muscle usually originate right at or below the popliteal fossa. So anytime you see mid-thigh varices, almost 100% is vein of Giacomini. This just shows you the schematic drawing, a publication we did in 2007, showing this is the true vein of Giacomini or the thigh extension. It can be multiple different presentations, but usually mainly 3. This is where it goes all the way from the short saphenous to the vein of Giacomini. Okay, this is all the way with a communication to the short saphenous vein. Sometimes there's no SP junction in these patients. This is what it looks like. You can see right here, this is the, go back here, sorry. This is Giacomini's vein, right here. It's Giacomini. You can see here, these vessels are coming up. They're going to pierce the fascia here. This is a semimembranosus muscle, tendinosus muscles here. This is the medial head of the biceps femoris here. Actually, so it looks like a saphenous vein in the posterior thigh is what it looks like on ultrasound. Go here, next one. So the anatomical presentation is how you treat it. EVLT is only possible in mid-thigh in most cases. You cannot get the laser filament or the radiofrequency catheter above mid-thigh because the vein becomes superficial, penetrates the fascia, and then connects to the greater saphenous. If you have a perforator, treat it with foam. You can treat, I've treated vena Giacomini's with laser and also just with foam. Both work. So whichever you want to do, it doesn't make any difference. It's going to work. If the vena Giacomini gives rise to varicosities, do a phlebectomy and then treat the vena Giacomini with foam. If there's short saphenous is involved, you can try to put the catheter up to mid-thigh and then ablate that too. But you know, foam's 100%, so it's a lot easier to do. Conclusion is that short saphenous insufficiency, Giacomini reflux are easily treated to mid-thigh with thermal ablation. Okay, or you can do foam sclerotherapy. My preference now, if I have a vena Giacomini without SSV insufficiency, is just to treat with foam. Don't even mess with it. Just treat with foam and do a phlebectomy. It's 100% curative. The recurrence rates for saphenous recanalization are similar whether you use foam or you use laser or you use RF. So if you're, if you're in a place where the problem is that we dictate, medicine's dictated to us by insurance companies. That's how we get paid nowadays. The insurance companies dictate us, the government dictates us. We don't do always what's best for the patient. Most of these patients could be treated very simply with foam sclerotherapy and very safely. Always do an exit phlebectomy. Take out that first branch. Thank you.
Okay. These cases that he's going to show are quite unusual and collected over a period of years, so I think you'll find them rather memorable.
Okay, thank you. But before we get started, no conflicts of interest for this, but I do want to still show, hoping my aneurysm case. Oh no, it's not in here. They were supposed to load. I give up. I had that popliteal aneurysm I was going to show, and it's not here. Anyway, so here's our first case. 40-year-old male presents with a third venous thromboembolic event in the last 2 years. Initially had a calf DVT after shoulder surgery. His second event was a spontaneous right below knee great saphenous vein superficial venous thrombosis, and his third was a small spontaneous PE. His medical history is relatively unremarkable, with the exception of a rotator cuff tendinitis, anxiety, irritable bowel syndrome, not inflammatory bowel disease. And he had an MVA at age 37, which required a splenectomy. And he's had right shoulder surgery as well. From a medication standpoint, he was on lubiprostone and aspirin. His warfarin was terminated about 6 months prior. And Lexapro, and no family history of venous thromboembolic disease. And this guy's had 3 venous thromboembolic events at a relatively young age. Physical examination is relatively unremarkable. He's of normal weight. Didn't detect anything unusual up in the right shoulder, no bruise, no increased venous collaterals. And his thrombophilia panel was normal, and his CVC was normal with the exception of Hal-Joel bodies, which you would expect after a splenectomy. And his platelet count was only about 400,000. Again, complete thrombophilia panel unremarkable. And I would ask you, what is the most likely cause of this patient's recurrent venous thromboembolic disease at the age of 37? Is it lubiprostone, splenectomy, a right shoulder AV fistula from his previous surgery, or JAK2 positivity? Okay. Yeah, sure. So the correct answer is actually splenectomy. So what data do I have to actually make that statement? Well, this is actually relatively recent data, which I encourage you to review. And this is data from Thompson. It was published in Journal of Thrombosis and Hemostasis in 2010, looking at the risk of venous thromboembolism in splenectomized patients compared with the general population, as well as appendectomized patients. And you can see here that, first of all, less than 90 days after undergoing a splenectomy, the risk of developing a DVT is 20-fold higher and 33-fold higher risk of developing a PE. I mean, that's pretty astronomical. Now, you may say, well, of course, the patient just had recent surgery. Of course it's going to be higher. Well, let's go out to 91 to 30, 365 days. Well, that elevation is still up to 7-fold. And then even 1 year after their splenectomy, that patient still has a relative risk for VTE that it's increased 3.5-fold after a splenectomy. And then you might say, well, gosh, these patients have ITP, they have myeloproliferative syndrome, myelodysplasia. That's what their risk is from. That's probably why they're having venous thromboembolic disease. But in this study, they actually looked at that, and they looked at patients that were previously young and healthy, and their only risk for having a splenectomy is they had trauma, and you can still see here that their risk of having venous thromboembolic disease was still increased 3.1-fold after undergoing a splenectomy. So there's something definitely linked to undergoing a splenectomy that increases a patient's risk of developing subsequent venous thromboembolic disease. And what about ITP patients? Well, we'll go right down here to the bottom. 90 days after a patient with ITP has undergone a splenectomy, their risk of developing a venous thromboembolic disease is still increased 3-fold versus that ITP patient that does not undergo a splenectomy. So what are some of the mechanisms that may underlie why the patient that undergoes a splenectomy has an increased risk of venous thromboembolic disease? Well, it may be the subsequent slight increase in platelet count, but probably it's related to a loss of filtering leading to an increased number of damaged circulating red blood cells, cholesterol, and a subsequent increase in CRP that stimulates hypercoagulability. And then, of course, a lot of these patients do have an underlying myeloproliferative syndrome that also contributes. But as you can see, when they looked at these patients that were previously healthy, even that doesn't explain it in some of these patients, like the patient that I saw. So it's interesting now that because of some of this data, which is contemporary data, a lot of the hematologists now are a little bit more hesitant to recommend that their ITP patient undergo a splenectomy, again, because they're cognizant of this link between splenectomy and subsequent venous thromboembolism. But now when I look back, now that I'm aware of this data, I've had a lot of these patients. I'm just going, why do these patients have recurrent DVTs that I can't explain? And it's because of that prior splenectomy. So just keep that in your differential. Okay, which of the following vascular disorders has the highest risk for venous thromboembolic disease? Is it this patient with bilateral pretibial plaques in the proptotic orbits that you see? Is it this patient that has these incredibly painful nodules on their legs and very, very sclerotic legs? And they were previously received that contrast agent there. There's my patient's arms, just very, very sclerosed, incredibly tender, narcotic-requiring, painful arms. Is it this patient that's had this congenital swelling in their left leg with a discoloration and some spider and varicose veins? Or is it this patient that simply has spider veins, a couple of reticular veins? Which of those patients is at the highest risk for developing venous thromboembolic disease? And anybody that's ever seen this particular patient, I guarantee you, has had this problem with their patient. So I heard somebody said the correct answer. And the correct answer is C, which is Klippel-Trenaunay syndrome. Klippel-Trenaunay syndrome is the triad of muscular and bony hypertrophy. It's a congenital swelling with associated capillary malformation or port wine staining, as well as spider and varicose veins. These patients are definitely thrombogenic. So what is the most frequent venous thromboembolic complication associated with Klippel-Trenaunay syndrome? And again, if anybody has this in their practice, you've already seen it, because they'll call your office usually at least once or twice a year complaining of this problem. The correct answer, in the interest of time, is superficial venous thrombosis. And that can be documented in, I've got 4 references here. The oldest one, venous thromboembolism, first of all, was historically reported in 8 to 22% of Klippel-Trenaunay syndrome patients. That's an older Mayo Clinic study. A more recent study from Duma, published just 2 years ago, looking at approximately 50 patients. About half of these patients had superficial venous thrombosis. And I've got a couple of these in my practice, and that's their typical presentation. They will call in a couple of times a year complaining of a painful cord on their leg. You can see the incidence of DVT and PE is lower. Similar figures in Oduber's study, which was published just last year, where 32% of the patients had superficial venous thrombosis, 4% with DVT, 1% with PE. So what are the mechanisms of hypercoagulability associated with Klippel-Trenaunay syndrome? Well, could be related to stasis within very distorted and enlarged veins. A lot of people say, well, about 10% of these patients at least have atretic or hypoplastic iliac veins. Maybe they have plethysmographic abnormalities or obstructive disease. But yet, when you look at Baskerville's study, they were unable to identify plethysmographic venous abnormalities within the calf of these patients. And really the current thought now, which was introduced by Mazoyer, is this phenomenon of localized intravascular coagulopathy, or LIC, within associated venous malformation. So as opposed to DIC, these patients have chronic LIC. And also, Oduber has recognized that compared with healthy controls, Klippel-Trenaunay syndrome patients have statistically higher plasma levels of D-dimer, also with a trend toward lower protein C and free protein S levels. And these D-dimer levels are directly proportional to the extent or the size of the vascular malformation. So and it intuitively makes sense. The larger the vascular malformation, the higher their D-dimer levels. And again, they have a chronic, I don't know what happened to they have a chronic LIC, or localized intravascular coagulopathy. All right, so moving right along to our, their video is ready. Just quick, if I could just show this will make my day to show this popliteal venous. Look at this. So if you had this patient that was asymptomatic, I think even Dr. Bush may even operate on this. I mean, look at that. Oh, yeah, well, not anymore. So you see, because he works in a derm clinic. But look at that. I mean, that thing's it's at least 4 centimeters, and look at that stagnant flow. So that's one I don't think there'd be a lot of equivocation. Probably want to operate on that, but pretty impressive. Okay, so thank you very much. I appreciate that. Back to our third case. Identify the most effective treatment for a spontaneous DVT-PE in this patient. Now you can see here they have some painful aphthous ulcers here on their inner lip, and they have pus or a hypopyon here in their anterior chamber. So I think, what disease is that? Behçet's disease, exactly. So how should you best treat this patient when they come in to see you with venous thromboembolic disease? Indefinite anticoagulation, immunosuppressive therapy, 3 months of anticoagulation, or indefinite anticoagulation plus antiplatelet therapy. Now, from an evidence-based standpoint, the correct answer is actually immunosuppressive therapy. Just to quickly review the diagnosis of Behçet's disease, it's made with recurrent oral ulcerations in the setting of 2 other findings, including recurrent genital ulcerations, eye lesions, skin lesions, or a positive pathology test. In addition, these patients are very prothrombotic and are prone to developing recurrent DVTs. If you've ever had a patient with Behçet's disease, you almost have a 1 in 2 chance they've had a concurrent DVT. Aneurysms, pseudoaneurysms, and surprisingly, there is no data, no corroborative data supporting anticoagulants or antiplatelet therapy in these patients. And this is a relatively recent study, 2012 by Du Bois. And look at the following comments. There are no large controlled studies regarding the best approach to Behçet's disease patients with thrombosis complications, and the exact role of anticoagulation therapy is still debated. Some authors recommend anticoagulants for major vein thrombosis, while others suggest that they be avoided owing to the increased risk of fatal bleeding from coexisting pulmonary artery aneurysms. Now, really, I don't think that's realistic in the United States. In the United States, you're still going to anticoagulate these patients, but if you look at the European data, they actually, a lot of times, do not anticoagulate these patients that come in with acute venous thromboembolic disease. Pretty amazing. In this study from Du Bois, it was a retrospective cohort study of 807 Behçet's disease patients. Almost 40% had venous thromboembolic disease. This is the largest cohort of Behçet's disease patients to date. Upon multivariate analysis, immunosuppressive therapy prevented relapse of venous thromboembolism with a hazard ratio of only 0.27. VTE relapses 20% even with immunosuppressive treatment, but almost 60% without treatment. Immunosuppressive treatment reduces the risk of VTE and Behçet's disease fourfold. And the medications most commonly used, azathioprine, cyclosporin, cyclophosphamide, and methotrexate. I follow a patient with rheum with this, and he's doing quite well on methotrexate. I initially saw the guy, and he'd had recurrent VTE all the way up into his cava, and until we actually made the correct diagnosis and put him on immunosuppressive therapy, he was failing everything, including enoxaparin. So you have to put these patients on immunosuppression. So what's the pathogenesis behind VTE in the Behçet's disease patients? Well, thrombophilia is unlikely. That's been checked ad nauseum. They're not thrombophilic from a conventional standpoint when you think of protein SC deficiency, et cetera. It's related to diffuse active inflammation of the venous endothelium. That's the bottom line. They also develop a neutrophilic vasculitis around the vasorum. And embolic events are rare as the thrombus is tightly adhered to the vessel wall. So that's why at least the Europeans a lot don't anticoagulate these patients, because that thrombus is so tightly adhered, it just doesn't tend to embolize. But again, in the United States, obviously you're going to anticoagulate these patients. And what's the most frequent venous thromboembolic complication in Behçet's disease? And this is all based on Du Bois' study, which again is the largest one to date. It's deep venous thrombosis. As seen in this table here, 96% of the patients had deep venous thrombosis. Second most common from at least a truncal or lower extremity standpoint would be within the inferior vena cava. And you can see Budd-Chiari syndrome is actually quite rare at 2.4%. Which venous thromboembolic complication in Behçet's disease is associated with the highest mortality? A PE, Budd-Chiari, superior vena cava thrombosis, or cerebral venous thrombosis? Again, this is all data from Du Bois study. And the correct answer is Budd-Chiari syndrome. And you can see here, if you had Budd-Chiari syndrome, your hazard ratio for mortality was almost a 10-fold increase. So even though it's rare, you don't want Budd-Chiari syndrome when you have Behçet's disease. So our next case, we've got a 56... Got to be done by noon. Okay. So this will be our last case then. You want to go into the one with the subclavian vein problem? Okay. So we'll terminate here. Interesting from a pathophysiologic standpoint. 57-year-old male presents with the following clinical manifestation. Got that painful red cord there along the medial thigh, and associated with a recent 22-pound weight loss and abdominal pain. Also has a cord along the forearm as well. So what is this? This is Trousseau syndrome. So which of the following is not a likely association with this patient's diagnosis? So microangiopathic hemolytic anemia, non-bacterial verrucous endocarditis, acute limb ischemia, or a thrombocytosis exceeding 600,000. Trousseau syndrome. Well, the correct answer is actually thrombocytosis. The above three entities are not uncommonly seen in the setting of Trousseau syndrome. And this is a busy slide, but just a couple of salient points as far as what underlies the pathophysiology of Trousseau syndrome. In the setting of typically adenocarcinomas, you elaborate cytokines, circulating mucin molecules, tissue factor, and all of these things lead to a DIC. which clinically manifest as arteriovenous thrombosis, a microangiopathic hemolytic anemia, or even a verrucous endocarditis, which of course can lead to acute limb ischemia. That was actually originally reported in Trousseau's series, acute limb ischemia from non-bacterial verrucous endocarditis. Now, although Trousseau syndrome is sometimes used to describe any thrombotic complication associated with cancer, from a purist standpoint, Trousseau syndrome should be restricted to unexplained migratory thrombotic events that precede or appear concomitantly with the visceral malignancy. Now, it's interesting, I actually gave this presentation in our hematology department, and one of the professors said, well, that's true from a purist standpoint, but who really cares and what does it matter? And, he's got a good point. But I think there is something unique to Trousseau syndrome from a teaching standpoint on why the therapy we use is effective and what is not effective. So what is the most effective therapy for the patient that has Trousseau syndrome? Heparin, warfarin or aspirin, or an NSAID? And hopefully everybody put number 1, which is heparin. So why is heparin the most effective therapy for a Trousseau syndrome patient? Well, early studies have emphasized the mucinous activation of thrombin or fluid phase blood coagulation in Trousseau syndrome, but contemporary studies, and these are all ones that have come out in the last 2 to 3 years, suggest that mucin activation of platelet-rich microthrombi, which are dependent on selectins, yet are independent of thrombin, actually underlie the hypercoagulability of Trousseau syndrome. You might say, who cares? Well, you should care because warfarin inhibits fluid phase coagulation, but warfarin does not inhibit selectins, whereas heparin prevents selectin binding, and that's why heparin works in the setting of cancer, but warfarin often is ineffective. And I guess in the interest of time, I'll just stop there. Oh, any questions about those? So if anybody's seen the Klippel-Trenaunay syndrome patients or having your practice, I'd be shocked if you have not had them call about superficial venous thrombosis, because I get those calls all the time. It used to be a real problem because we'd put them on, a couple of my patients, you'd put them on noxapirin, let's say, for 3 to 4 weeks, and it was always a pain with injections. But now with the novel oral anticoagulants, it's a lot easier just to put them on a low dose of those and treat them. Much easier. Oh, thank you. Question?
One question?
Can I just add, this seems to be the most appropriate place to say this. This is my own personal experience that would sort of fit in with this type of presentation. I had hip replacement, DVT, PE, Coumadin for a number of years, went for a prostate procedure, asked the physician to bridge me when he took me off of Coumadin, did not, had tachycardia post-procedure, and was told by an authority that a large percentage of prostate manipulation patients develop pelvic clots. So I wanted to mention that so that that could be investigated by the group, at least thought about.
Good point. Now, you're saying they didn't bridge you post-operatively? Yeah, I wouldn't have necessarily bridged you pre-operatively if you had not had an event within the last 3 to 6 months, but post-operatively, I certainly would have bridged you. Definitely.
And also, the last point on that, it's my understanding once you come off Coumadin, you become hypercoagulable as you're getting into a therapeutic range again. So the process of bridging, based on what I've been told by pharmacists, might be more important than we realize.
Yeah. Okay.
Thank you, Steve. Thank you very much. Now, I'd like to let everyone know that Covidian is sponsoring a hot lunch buffet next door for the noon luncheon. If you'd like to go right next door, there's a buffet. If you prefer to not attend, then there's a box luncheon available in the corridor there. And we'll start the second afternoon session at 1:15. So we'll see you back here then. Thank you.